Good morning, and it's an honor to be a part of this really important conference. And I'm really excited to share with you this morning an overview of the current US maternal health care crisis. So I want to start by just making sure that we're all on the same page and realizing that this discussion today has implications for Black, Brown, and Indigenous birthing people as well. I will refer to women to describe pregnant individuals. However, I recognize that people of various gender identities, including transgender, non-binary, and cisgender individuals, give birth and receive maternity care. I think there's a long legacy of racism and discrimination in this country that's been experienced by Black women, and most of the research to date has been on cisgender women. We have a lot of work to do to expand our definitions and collect more meaningful data on all birthing people. So I think it was around 2010 that Amnesty International published Deadly Delivery, which was a report that really documented our high rates of maternal mortality and our significant racial and ethnic disparities in this outcome in the United States. And over the next decade, there was a growing recognition of this public health crisis. We got more and more media coverage, including the NPR ProPublica series in 2017 and 18 called Lost Mothers. Again, this coverage really focused in on the fact that the majority of these deaths are preventable, the significant racial and ethnic disparities. And over again, we heard how hospitals and our healthcare system was really failing women. Even the recent estimates for our maternal mortality in this country that came out by the CDC using 2018 data showed that our rate was 17.4. Again, that rate put the US last among similarly wealthy countries. And if you compared that CDC figure to the World Health Organization's latest mortality rankings, we ranked 55th. It's important for us to be very clear about the definitions that we're talking about. So let's just remind ourselves that when we talk about pregnancy-associated deaths, we're talking about deaths that occurred during pregnancy and up to 1 year postpartum of all causes. When we speak about pregnancy-related mortality, we're describing a death of a woman during pregnancy or within 1 year at the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiological effects of pregnancy. Again, this metric is used by the CDC to report US trends. And again, it's a ratio per 100,000 live births. And then finally, the one that we've heard so much about in the news is maternal mortality, the death of a woman during pregnancy or within 42 days of the termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Again, this metric is used by the World Health Organization, and it's what we hear about often when we're talking about international comparisons. So regardless of which metric we use, pregnancy-related mortality, again, deaths up to 1 year, we're not doing well in this country. And here's data from the CDC showing a climb from 1999 through 2016. The leading clinical causes of pregnancy-related mortality in the United States. So again, here's data from the CDC looking from 2007 through 2016 and showing us the major clinical causes. And as you can see, cardiovascular conditions are a major cause and have actually increased over the last decade in terms of causes for pregnancy-related mortality. Infections, severe bleeding, cardiomyopathies, blood clots are all leading causes of pregnancy-related deaths. It's very important for us to not forget important maternal self-harm deaths, which are often classified in the pregnancy-associated death category. We hear over and over again in the news how suicide is a leading cause of death among moms and how the rates are increasing across the country. We've heard this from multiple maternal mortality review boards that review deaths. The US opioid crisis. We know the rate of overdose for deaths among women has increased. We know that opioid use disorder among pregnant women has gone up more than 4 times. And we know that 4 times as many infants were born with neonatal abstinence syndrome in 2014 than in 1999. These deaths are underreported. Often on the suicide deaths, pregnancy status is unknown. They seem to occur much later in the postpartum period, between 9 and 12 months. We know major risk factors are depression, substance use disorder, intimate partner violence. And in a review of maternal mortality deaths from 9 states, they looked at the common themes that were related to these mental health causes. And they found that it was inadequate assessment of risk, failure to screen, ineffective treatment, delay in diagnosis, treatment and follow-up, and then lack of coordinated care and lack of communication. Interestingly, between 2007 and 2016, among the 22 states with the pregnancy checkbox, they found that maternal mortality involving opioids had doubled during this time period. And even in Philadelphia, where I am now, in the most recent maternal mortality report, overdose deaths accounted for 40% of pregnancy associated deaths. Well, another big issue when we think about maternal mortality in this country are the long-standing and significant racial and ethnic disparities. And we have heard through ProPublica and NPR multiple stories of the lost lives of women and birthing people. And here in the upper right-hand corner is Dr. Shalone Irving, that I think this audience has probably heard the story of. She was 36 years old. She delivered her first child by cesarean. She went home from the hospital, and 3 weeks later, she died from complications of hypertension. She was seen 4 or 5 times in those 3 weeks. And her mother has shared such compelling stories across the United States about this tragic death. The next picture is of Rosa Diaz, and she was featured in a ProPublica piece on the extraordinary danger of being pregnant and uninsured in Texas. She was a person who did not have health insurance, did not go in. She had a ruptured ectopic, and she bled to death at home. Here is data from the CDC documenting pregnancy-related mortality ratios by race and ethnicity from 2007 through 16. And you can see, as documented in this slide, that Black women are 2 to 3 times more likely to die from a pregnancy-related cause, and Indigenous women are over twice as likely to die from a pregnancy-related cause as compared to white women. We know these disparities are much more pronounced in some of our cities. For example, in New York City, the most recent data from the Department of Health and Mental Hygiene has shown that Black women are 8 times more likely to die. And in Philadelphia, the rate is, in Philadelphia, it's 4 times. Really important for us to acknowledge, this is not a new story. From the time they first recording in 1916, we've seen a Black-white gap. And while the improvement in the dramatic decline in maternal mortality overall in this country during that century, because of healthier living conditions, improved maternity services, safer surgical procedures, antibiotics, etc., we saw this Black-white gap increasing to the 1970s, where it hit around 4 times. And then you can see that it's been consistently somewhere between 3 and 5 times over the next 40 years. It's important for us to recognize that when we're talking about a disparity, we are not talking about a simple difference. We are talking about something that's unjust, as Margaret Whitehead referred to in the early 1990s at the WHO. Here's a definition by Paula Braveman from UCSF. Health equity and health disparities are intertwined. Health equity means social justice in health, that no one is denied the possibility of being healthy for belonging to a group that has historically been economically, socially disadvantaged. Health disparities are the metric we use to measure progress towards achieving health equity. Again, we need to recognize that these disparities go beyond class. Data from the CDC showed us that Black women with a college education were more than 5 times as likely to die from a pregnancy-related cause as compared to white women with a college education. And here is data from 14 US maternal mortality review boards that looked at the underlying causes of pregnancy-related deaths. And you can see that cardiomyopathy, cardiovascular conditions, and preeclampsia and eclampsia were the leading causes among Black women, while mental health conditions, cardiovascular conditions, and hemorrhage were the leading causes among white women. More recent research utilizing national data suggests that leading causes of death for Black women, eclampsia, preeclampsia, and postpartum cardiomyopathy, that those are the leading causes, and that rates are 5 times higher among Black than white women. This is data from a recent paper from McDormand that was published in AJPH, where the team really looked at causes of death, literals on the vital statistics to get much richer detail about the conditions surrounding death. I think something that we've been learning more and more about over the last 5 years to 10 years is really recognizing that when we're thinking about pregnancy-related death, we need to really understand the timing. And what we've learned is that these deaths are much more common in the postpartum period than we really initially recognized. And in fact, on this slide, you can see that deaths from day 1 postpartum through 12 months postpartum, that the majority of deaths occur during this period. It's important for us to think about the timing of deaths because we can better then understand what are the leading causes at the different time periods and then intervene. You can see here on the slide around cardiovascular conditions, in antepartum, day of delivery, or more around hemorrhage and amniotic fluid embolism. In that first week postpartum, we're seeing more around hemorrhage and hypertension. 7 to 42 days is more about infection and cardiovascular conditions. And then finally, in those, 6 weeks to a full year postpartum, their cardiomyopathy is the leading cause. And we know there are significant racial and ethnic disparities in the occurrence of postpartum cardiomyopathy. As this audience is well aware, a pregnancy-related death or a maternal death is just the tip of the iceberg. For every maternal death, over 100 women experience a severe maternal morbidity, and that results in over 50,000 women every year in the United States having one of these events. Work by the CDC really helped us use administrative data to sort of help define this, and included things like organ failure, amniotic embolism, eclampsia, and life-saving procedures such as transfusion, hysterectomy, and ventilation. Similar to the story that I've told you about pregnancy-related mortality and racial and ethnic disparities, you can see racial and ethnic disparities in severe maternal morbidity. And here is data from the nationwide inpatient sample showing that when you look at each of the underlying diagnoses that make up severe maternal morbidity, you see that Black women and indigenous women have higher rates. So how might we put this together and think about what are the pathways that shape and result in severe maternal morbidity and mortality overall, and then specifically around racial and ethnic disparities? I'm a health services researcher, and so I think about this framework, and starting with the structural racism and discrimination that shapes the policies and processes that in the legacy in this country. We can think about patient community, clinician, and system factors such as sociodemographics, education, poverty, employment, language, knowledge, beliefs, stress, social support. We can think about community factors such as the built environment, social network, housing, clinical factors such as knowledge, experience, implicit bias, which we just heard a really compelling talk on to remind us of what a huge role that plays in the way that we communicate and interpret other people, communication, and then system factors, access to high quality care, transportation, structural racism again, and policies. These combine to create the health status of a woman when she becomes pregnant. She may or may not have comorbidities that put her at an elevated risk. And then she interacts with the healthcare system, preconception care, antenatal, delivery, and postpartum care. An important part of this story is results from multiple maternal mortality review boards across the country. CDC has reported that over 60% of these deaths are thought to be preventable, making quality of care a critical lever to address this issue. And now I'm going to just share some of the research that our team has done looking at the ways in which quality of care contribute to racial and ethnic disparities in severe maternal morbidity and mortality, and actually overall to these alarming statistics. So we had funding from NIH to really think about hospital performance on the metric of severe maternal morbidity in New York City hospitals. And we used birth certificate data linked with state discharge abstract data. We created risk-adjusted models to understand performance. So again, we risk-adjusted for sociodemographics, clinical factors, and looked at how hospitals, the 39 delivery hospitals over this period, compared on risk-adjusted rates of severe maternal morbidity. And this slide shows you that there was a 6 to 7-fold difference in the risk of having a severe maternal morbidity from one hospital to the next. And we also found that Black and Latinx deliveries were much more likely to occur in the hospitals that had the worst outcomes, the highest rates of risk-adjusted severe maternal morbidity, really suggesting that between hospital differences and the fact that Black and brown women were delivering in different hospitals was part of the story of the elevated rates of severe maternal morbidity in New York City. We then went on and said, what is it? Why is there this 6 to 7-fold variation across hospitals in this metric? And could we understand that better? So we did qualitative interviews, really sort of looking at structural characteristics, organizational factors, clinical processes. We went to a cluster of hospitals that had low rates of risk-adjusted severe maternal morbidity, and then a cluster of hospitals that had high rates of risk-adjusted morbidity. And we asked questions around these issues. We layered the questions with disparities, questions around disparities, bias, diversity, and communication. And in these qualitative interviews, we spoke with chairs of OB, labor and delivery nurses, frontline nurses, head nurses on labor and delivery, physician quality leads, and really tried to get a sense from the providers about what was going on and how they interpreted this. And really, there were a number of shared themes, and this is just a quick summary. But and this was about 3 or 4 years ago. So the shared themes, whether hospitals were low or high performing, was around staffing issues around nurses, and this was before COVID. The wide variation in quality measurement and improvement, and that at that time, no one was really analyzing data to compare performance across race, ethnicity, or insurance. We did find that high-performing hospitals were more likely to have a stronger focus on standards and standardized care. They had a stronger focus on nurse-physician communication and teamwork, and with sharing performance data with frontline clinicians. And there was more awareness that disparities and racism could be present in the hospital and could lead to differential treatment. We also did work with women who experienced severe maternal morbidity in focus groups to try to better understand what their barriers were to care. And we found some themes such as the significant trauma that women go through who have experienced severe maternal morbidity. Women over and over again spoke about communication failures and people not listening to them. And then for the Black and brown women and those focus groups, we found a lot about subtle forms of discrimination and lack of continuity of care and issues around education. Now, I've told you the story of these between hospital differences in severe maternal morbidity rates across New York City, but we also wondered, what about within a hospital? Are there racial and ethnic disparities in severe maternal morbidity after we account for insurance status and other sociodemographic and clinical factors? Because again, we thought that because there were many places in New York City that actually had resident clinics that primarily cared for Medicaid managed care patients and Medicaid patients versus commercially insured patients being seen elsewhere, could that really be the underlying cause? And what we found is no, that was not the case. We found that women insured by Medicaid and those with commercial insurance had similar risk for severe maternal morbidity within any given hospital. However, we found that Black women compared to white women and Latino women compared to white women had elevated rates of severe maternal morbidity after we accounted for health insurance and all those other factors. In additional research, my colleague led some work really trying to better understand how racial and economic segregation might be associated with severe maternal morbidity rates, and whether the delivery hospital might explain some of this association. And what she found was that the zip codes with the highest concentration of poor Blacks relative to wealthy whites experienced twice as many severe maternal morbidity cases as compared to women in the neighborhoods with the lowest concentration. And women in highly racially and economically segregated neighborhoods were the most likely to deliver in hospitals located in similarly polarized neighborhoods. So in other words, racial segregation in neighborhoods is also part of this story. And you can see here on the right, that was a map that she created that really shows that the red are the neighborhoods in New York City with the highest rates of severe maternal morbidity. And interestingly, they're very similar to the rate to the maps showing the rates of COVID infection in New York City. So how might we move forward, and what are the levers that we can utilize to reduce morbidity and mortality? I think one of the things we heard about earlier is the importance of a life course perspective on women's health in general, but so important when we're thinking about morbidity and mortality. We interact at in preconception and thinking about culturally sensitive and patient-centered contraception, optimizing preconception health. When we think about antenatal care, we think about new models of care centering medical homes. When we think about quality improvement, delivery and hospital care, we can think about standardization, bundles, disparities dashboards where we stratify metrics by race and ethnicity. And again, later in the day, you're going to hear some of the research that's been done in these spaces around how do we, if we implement bundles, how might that actually improve quality and then reduce disparities. The other area is on postpartum and thinking about navigators and case managers and community health workers and all those new models of thinking about how we enhance postpartum care. We have to address and think about the ways to eliminate bias, to both implicit and explicit. Again, we heard a compelling talk about how much that may impact the way that we think about not only in our hiring, but also in our delivery of care. We need to think about ways to enhance communication, not only between patients and providers, but between our teams, nursing, physician, and our other folks on the care team. And we really need to think about ways that we can engage community in trying to reduce morbidity and mortality. There's a lot of research gaps in this space around doulas, community health workers, navigators, coaches, and when's the best time to use them? How might they impact pregnancy outcomes? There's so many research gaps in this entire space. And I'm hoping that the conversation later this afternoon will talk about these. And finally, I'd just like to touch on a few points as we think about a path forward for NIH. I truly believe that putting the National Institute for Minority Health and Health Disparities has changed the landscape for how much funding is being put forth for racial and ethnic disparities in this country. And I would like to challenge this group to think about having an institute for women's health and think about what would the implications to amplifying research on women's health. We've heard earlier about how we need to expand research on pregnant women and long-term health outcomes, invest in health services research, enroll pregnant women in clinical trials. And then I'd like to just also say there's a whole side on GYN and gynecology that's underfunded. And we need to think about some of the research that OBGYNs do and having a place and a home for that. Here's the final quote from Dr. Cooper. Most health disparities are avoidable. They result from decisions we make as a society regarding how we allocate our resources and how much injustice we are willing to accept as a fact of life. Thank you.